I'm Dr. Kevin Darr. I'm an orthopedic surgeon in Covington, Louisiana, in private practice. And I'm pleased to talk to you today about the clinical outcome of patients following combined cell therapy for the treatment of pain and functional deficits associated with OA of the knee. OA is one of the most common chronic and debilitating conditions seen in the orthopedic setting. Successful treatment of OA remains a challenge, particularly due to lack of blood supply and limited capacity of self-repair in articular cartilage. Traditional treatment is aimed at symptom management to control pain and restore function, but nothing reparative in nature to alter the progression of disease. The initial approach to OA begins with activity modification, rest, heat, and ice. Physical therapy, strength training, and aerobic exercise can help alleviate the symptoms. Bracing, topical creams, over-the-counter anti-inflammatory medications, and steroid injections are also treatment options. More advanced cases of OA can be unresponsive to traditional pharmacological methods, warranting surgical intervention. Surgical treatment can be challenging, may require prolonged rehab, and can have some complications, which often leads patients seeking out other, less invasive options. There's a treatment gap in which patients are not satisfied with, are no longer responding to traditional care, and either not ready or unwilling to move forward with a surgical approach. Regenerative medicine has allowed for a more holistic, reparative approach to treatment of such conditions. The therapeutic use of mesenchymal stem cells is related to both their anti-inflammatory activity and their chondrogenic potential. Combined use of autologous bone marrow, fat graft, and PRP have successfully modulated both pain and functional deficits associated with OA. In combination, their interaction with the local microenvironmental niche at the targeted injury site guides and further enhances the activation and proliferation towards site-specific cell types, therefore enhance reparative abilities. The fat provides a living bioscaffold of cells and stromal elements to which the BMAC adheres and modulates the inflammatory and reparative response. PRP further enhances these effects via cytokine secretion and activation of autocrine and paracrine pathways. Obtain a PRP via routine blood draw. PRP initiates the clotting cascade, increases capillary permeability, stimulates the proliferation of new fibroblast development, as involved in the remodeling process by stimulating angiogenesis of mesenchymal stem cells and also increasing the migration and production of native stem cells. The second component of combined cell therapy is concentrated bone marrow aspirated from the iliac crest, which is an abundant source of mesenchymal stem cells that are multipotent and allow for the creation of new cartilage. Cytokine secretion by the mesenchymal stem cells in the BMAC controls the inflammatory activity as well as proliferation and differentiation of other cells critical to healing. Mesenchymal stem cells can differentiate into cell type surrounding them. The third component of combined cell therapy is the fat graft, which is obtained by a mini lipoplasty procedure, usually from the abdominal or flank area. This tissue is put in a centrifuge to clean the fat graft and remove the inflammatory oils and are activated via UV light. The fat graft serves as a living bioscaffold for the stem cells and growth factors. Adipose tissue has a well-described microvascular network with an extracellular matrix and extensive perivascular stroma. All three components of cell therapy are injected under ultrasound guidance and together interact with the local microenvironment that ultimately guides the activation and proliferation of cell types and reparation of degenerative tissue. In the current study, participants ranged in age from 38 to 90 with a diagnosis of OA to the knee. Data from 140 knees, 96 patients were initially examined. Those with scores less than or equal to 15 over 100 were deemed not active presentations and were therefore not included in the study, as any treatment would be considered prophylactic. Based on this screening, data from 116 knees were included in the final analysis, with 23 mild OA, 49 moderate, 44 severe. Baseline evaluations were performed, and patients were reevaluated at 6 weeks, 18 weeks, 1 and 2 year results. No significant complications were reported. This is an x-ray of a patient with KL3 in his knee with medial joint space narrowing, as shown in the image on the left. The patient received combined cell therapy. The x-ray on the right shows 1.5 millimeter increase in joint space in the same knee 4.5 years post-treatment. This 23-year-old male had an MRI showing focal osteochondral lesion involving the lateral femoral condyle. 1 year out, combined cell therapy, the patient's MRI showed that the osteochondral lesion had resolved, and clinically, the patient reported 69% improvement in function and 61% improvement in pain. These are graphs of the normalized mean deviations from baseline of VAS and Kuss-Womack for mild OA indicated in blue, moderate OA purple, and severe red, measured during each follow-up endpoint up to 2 years. Quantitative comparative analysis was performed using GraphPad Prism 8. The level of significance for all hypothesis tests was set at 0.05. Continuous variables were presented as mean and standard error. Comparisons of knee VAS and Kuss-Womack were independently made with the Kruskal-Wallis test for each data set, revealing statistically significant changes from baseline values among all data with a p-value of 0.001. In all cases, and it is indicated on the top line in each graph. Post-hoc analysis was then performed using the Wilcoxon signed rank test to delineate the improvement of measurements between each endpoint with 95% confidence intervals. Post-hoc analysis for mild, moderate, and severe revealed statistical improvement in VAS and Womack scores through 18 weeks with a maintenance of those results up to a year and an improvement thereafter at 2 years. While the trends showed continual improvement over time for mild OA cases, there appeared to be a plateau and maintained improvement from 18 weeks to 2 years for moderate OA. The trends revealed improvement up to 18 weeks for severe OA with the maintenance of those results or slight worsening at a year post, followed by symptom improvement between 1 and 2 years post-combined cell therapy. All 116 patients completed the 1-year follow-up, and 88% of those patients showed improvement. 47 of the 116 patients completed the 2-year follow-up, and 95% of these patients showed improvement. In order to account for any data skewing caused by the loss or retention of patient at the 2-year follow-up, we decided to examine these numbers more closely with a more stringent paired analysis of these data points. This is a plot of parallel bar graphs showing 1 and 2 year results of mean percentage improvement. There was no statistically significant difference between 1 year and 2 year VAS among all OA groups. However, the severe OA group was very close, and the trends suggest improvement at year 2, which is why it is demarcated with a plus. This is a plot of parallel bar graphs showing 1 and 2 year results of mean percentage improvement in Kuss-Womack. There was no statistically significant difference between year 1 and 2 among all OA groups. However, the severe OA group was very close, and the trends suggest improvement at year 2, just like the VAS. These are plots of yearly VAS measurements to compare the outcome among OA severity groups, showing statistically significant improvement in year 1 combined cell therapy VAS scores in mild OA versus severe with a p-value of 0.001, and enhanced improvement in moderate OA when compared to severe VAS scores with a p-value of 0.01. No significant difference was found between mild and moderate OA VAS results. The bottom plot shows statistically significant improvement in year 2 post-combined cell therapy VAS scores in mild versus moderate with a p-value of 0.01. No other significant differences was found between mild and severe and moderate at 2-year VAS results. There was statistically significant enhanced improvement in 1 year post-combined cell therapy Womack scores in mild OA versus severe and versus moderate OA with a p-value of 0.01, and enhanced improvement in moderate OA when compared to severe in 1 year VAS with a p-value of 0.01. The bottom plot shows significant enhanced improvement in 2-year post-combined cell therapy Womack in mild versus moderate OA and mild versus severe with a p-value of 0.01. No significant difference was found between moderate and severe 2-year Womack results. The results of the study support the hypothesis that combined cell therapy can greatly reduce pain and increase function in patients diagnosed with OA of the knee. Degradation of cartilage and bone caused by OA is slowed and even halted in some cases, particularly those who use the therapy as early intervention. Combined cell therapy can serve as an alternative method of conservative treatment for patients who are unwilling or medically unable to undergo surgery or want surgery as a last resort. If administered early, these treatments may lead to longer lasting benefits and less likely developing progressive OA. Thank you.